Hello everyone, welcome to this lecture on enteric fever, that is typhoid and paratyphoid. We have already discussed about Salmonella and the introduction to the typhoid fever in part 1. Today we are going to discuss the clinical features that we see in a typhoid patient as well as the investigations that are required to diagnose the typhoid disease. So what knowledge we gained in the part 1, we know that the Salmonella is gram-negative and flagellated rods, and this small rod, this small bacteria can cause gastroenteritis, and severely it may cause enteric or typhoid fever. Salmonella enterica, serotypes typhi and paratyphi ABC, these serotypes causes typhoid and paratyphoid fever, while serotypes enteritis and typhimurium they causes the gastroenteritis. Okay, and the salmonella survive in the phagocytic cells such as macrophages and dendritic cells, and it causes typical lesions in the Peyer's patches in the intestine, such as we can see here. It is a ulcer. Okay. In some cases, the patient may become a chronic carrier, and the bacteria survives in the gallbladder and passes the bacteria intermittently in the stool. And the lab identification includes the blood culture as well as one important commonly used test, that is Vidal test. Okay. Today we are going to see that what are the various clinical features in the typhoid as well as in paratyphoid, and the various complications as well as the investigations. So first of all, the clinical features of the typhoid fever. One important thing is that this fever is rise in a step ladder fashion for 4 to 5 days. So what is this step ladder fashion actually? This is step ladder fashion. Each day the temperature rises, then almost remains like that, then again rises, then remains like that, then again rises. So it becomes a ladder kind of. Okay, so it is known as step ladder fashion. It is particularly important for the typhoid fever diagnosis. Okay, as well as when you will give the therapy, then it goes down in the step ladder fashion also. Okay, and with this fever the patient may have symptoms such as malaise, means in Hindi we can say the bechani in the patient, as well as there may be headache, there is drowsiness, and there may be myalgia, means aching in the limbs are present. Okay, in the starting phase especially. So in the first week, the patient may have fever, the patient may have headache, the myalgia, constipation is there. In the initial phase, the constipation is because of the swelling of the lymphoid tissues. Okay, in the ileocecal junction where there are Peyer's patches also and other lymphoid tissues, these lymphoid tissues get swelled. It causes the blockage at the ileocecal junction, which causes the constipation. However, in children, diarrhea and vomiting are more common. Okay, it is more common in the early phase in the children. So as well as one more thing is the relative bradycardia. What does it mean? It means that we know that the patient is in fever, and if a patient is in fever, then the heart rate should be higher, but in these patients the heart rate is lower. Although patient is in fever, still the pulse is often slower. That is why it is known as relative bradycardia. So these are the symptoms in the first week: fever, headache, myalgia, then relative bradycardia, constipation in adults, and in children diarrhea and vomiting. Now at the end of first week, one more important symptom we see is the rose spots. So these rose red spots are present on the trunk which feeds on the pressure. Okay, so these kind of red spots are present, as you can see there, it is highlighted. Okay, so these are rose red spots, and when you will apply the pressure, they fades. It is seen in the first week, at the end of first week. So at the end of first week, rose spots on the trunk, as well as the patient may have abdominal distension, and the constipation which was there in the starting, it will be followed by the diarrhea in the patient, as well as there may be some abdominal tenderness may also present, and splenomegaly may be present, as well as coughing is there. Okay, and if this all remains untreated, then by the end of second week, the patient may be profoundly ill, and the symptoms such as delirium and many other complications are present, and then the coma and death is there. Okay, so the end of first week, we have rose spots, we have abdominal distension, we have diarrhea, we have tenderness in the abdomen, we have splenomegaly, we have cough or bronchitis is there, and at the end of second week, if the patient is not treated, then the patient may have the delirium and many other complications. Okay, all this is there. So what are the clinical features in the paratyphoid fever? In the paratyphoid fever, the features are usually shorter than that of typhoid fever, and there is abrupt onset with acute enteritis is present in the paratyphoid fever, and rashes may be more abundant than the typhoid fever. All this is there. However, the most common is typhoid fever. So we saw that in the typhoid there are rose spots. Okay, rose spots is a maculopapular rash, or we can simply say the erythematous rashes are there. The DD of these rashes includes dengue, HIV-1, spirilla minus, rickettsial infections, or measles. Okay, however, in our daily practice, we will have to see the dengue, especially if it is a season where there are the dengue patients are coming, then you will have to make a DD of the dengue and the typhoid if there are rashes present, as well as measles if the patient is a child. Now, what are the complications? If patient is untreated, then those Peyer patches which are ulcerated may have hemorrhage or may be even perforate. And if they will perforate, then it may cause sepsis. Okay, this all happens at the end of second week or during the third week of illness. It is a one very important complication of the typhoid. As well as there are other complications. We saw the perforation, we saw the hemorrhage in the bowel, as well as there may be bone and joint infections, there may be cholecystitis, meningitis, myocarditis, nephritis, or the patient may become chronic carrier. So there is persistent gallbladder carriage of the Salmonella. So in the chronic carrier, we have to discuss this because it is usually asked, who was the typhoid Mary? Well, she was Mary Mallon. She was a cook, and she was a first known case of a healthy carrier of Salmonella typhi. Okay, she was a healthy carrier of Salmonella typhi, and she was nicknamed as Typhoid Mary, which became synonymous with the spread of disease as she infected many as a cook. Okay, she infected many people when she was a cook because she was a chronic carrier. Now, how can we diagnose the typhoid? The investigations which we can do. First of all, the first week is very elusive. It is tough to diagnose in the first week, okay, because symptoms are those of a generalized infection. So it is not easy. However, you may find the leukopenia in the CBC, means complete blood count of the patient. You will find the leukopenia. If you want to confirm the diagnosis early, then the blood culture is there. It can detect the bacilli in the first week, as well as stool cultures are there. However, they become positive in the second or third week. One important test is the Vidal test. Okay, so what is this Vidal test? We saw that the Vidal test detects antibodies to the O and H antigens of the Salmonella. Well, the Vidal test is a serial dilution method. Here is the serial dilution, and there are different titers: 1:20, 1:40, 80, 160, then 320, then 640. These are all different titers, and we will add antigens here, and we will see that which one is have the agglutination is there. Okay, so the positive, we say if it is above 160 or 160 is there, means the result is positive if there is some agglutination in the 160, then 320, then 640. Okay, however, the 1:80 is suspicious, while 160 is strongly suggestive of infection in unvaccinated individuals. Okay, however, if the patient is vaccinated, then the titers are much higher. Okay, but most of the population of India is unvaccinated, so the 160 or above is considered as positive in the typhoid. It is a very important and very commonly used test. But let me tell you one thing, that the Vidal test is positive only after 7 to 10 days of the onset of fever. So if you have fever starting from today, then Vidal test will be positive only after 1 week or so. Okay. So the before 1 week, if you are doing the Vidal test, then it is inconclusive. Okay. So it is one important thing to learn. Now the H antigen antibodies appear late than the antibody against O antigen. So the O antigen antibody is more important one for the earlier diagnosis, and the H antigen antibodies disappears later than the O antigen antibodies. However, if you want to diagnose a carrier, then the V antigen for the Salmonella typhi is used. Okay, so the antibodies to the V antigen, VI antigen are positive in almost 70% of chronic carriers. Okay, thank you. Do subscribe, like, and share. So then what knowledge we gain today? We now know that the typhoid fever is of a stepladder fashion, and the patient usually present with a malaise or bechani and headache, drowsiness, myalgia, constipation, and diarrhea. Abdominal pain is there. Rose red spots are there in the second week. Splenomegaly is also present. Ulcerated Peyer's patches are there, which may hemorrhage or perforate, and they are chronic carriers in the gallbladder, and the bacilli pass intermittently in the stool. One example, we saw the typhoid Mary, and investigation includes leukopenia, which is seen, and for the earlier diagnosis we use blood culture, and the Vidal test is there, which is positive if the titer is 1:160 or above, which is positive usually after 7 to 10 days. You have an assignment. What are the other causes of small intestinal ulcers? Share in the comment section. These are the references. Thanks a lot.